and gentlemen, welcome to another exciting academic web series under the aegis of Mumbai Hematology Group. And today's topic is DLBCL Management. This web series is courtesy Mumbai Hematology Group and the gentleman on the screen today, our program director, Professor Dr. M.B. Agarwal, sir. He's had the privilege, I would say, that he's been able to pull off all the leading authorities, subject matter experts ever since COVID happened using web platform. And I would say that probably it could be one of the Guinness record, I must say. An institution in himself, inspiration for many teachers of teachers. And we in India is fortunate to have you, sir, who have been enriched by your academic collaborations with stalwarts in the field of hematology, you being a leading stalwart in the field of hematology yourself. No wonder, many awards and accolades to your credit, including the Inspiring Hematologist of India by Economics Times. Thank you for doing this every week and every weekend, sir, and may I request you to take it forward from here.
Thank you, Dr. Manoj, for those kind words. Good evening to one and all, and good morning, good afternoon to those who are logged in from the other parts of the world. Today, our guest speaker is Dr. Priyanka Pofle. She's from Wisconsin, USA. She's going to lecture on diffuse large B-cell lymphoma, its management in 2023. This webinar is brought to you by Mumbai Hematology Group. It is supported by INTAS, and I must thank Dr. Manoj and his team for relentlessly supporting our webinars for last 3 years, almost about 2 or 3 episodes per month. This is managed by Perfect Square. I thank Dr. Manoj Kumar and his team from INTAS, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker this evening, Dr. Priyanka Pofle from Wisconsin, US. All our discussants were themselves eminent hematologists or medical oncologists. You participants for sparing your Saturday evening, morning, or afternoon. Tomorrow morning at 11:30 a.m. IST, we have Dr. Martin Skrippi from Kiel, Germany, speaking to us on childhood acute lymphoblastic leukemia, unsolved problems in 2023. Our discussants today are plenty of very important personalities, alphabetically put up over here. I won't have time to introduce them fully to you, but I'll just briefly tell their names and the city to you. So we have Dr. Akanksha Mandloi from Varanasi, Dr. Aditi Thanki from Rajkot, Dr. Amit Khurana from Surat, Dr. Anushri Chaturvedi from Varanasi, Dr. Babita Hapani from Rajkot, Dr. Chirasri Sanyal from Kolkata, Dr. Dilip Gohokar from Nagpur, Dr. Gunjan Lone from Nagpur, Dr. Karthik Kumar from Rishikesh, Dr. Ketan Modak from Nagpur, Dr. Kunal Chattani from Nagpur, Dr. Kunal Goyal from Varanasi, Dr. Maupali Ghosh from Kolkata, Dr. Muralidharan C from Mumbai, Dr. Neha Ganju from Nagpur, Dr. Nitish Dakate from Nagpur, Dr. Rahul Arora from Nagpur, Dr. Riya Balikar from Nagpur, Dr. Saswata Saha from Mumbai, Dr. Siddharth Sankare from Kolkata, Dr. Sisir Patra from Kolkata, Dr. Soumya Mukherjee from Kolkata, Dr. Sujit Kumar from Varanasi, Dr. Suman Mittal from Raipur, Dr. Sundar Shevale from Kolkata, Dr. Shweta Banka from Nagpur, Dr. Tufan Dolai from Kolkata, Dr. Vinod Patil from Satara, Dr. Vishwadeep Khushru from Nagpur, Dr. Yashwant Kashyap from Raipur. Briefly, to introduce Dr. Priyanka Pofle to you, she is Assistant Professor, Lymphoma, CLL, and Cellular Therapy, Division of Hematology, Oncology, and Palliative Care, Department of Medicine, University of Wisconsin, Carbon Cancer Center, Wisconsin, US. She received her medical degree from Indira Gandhi Government Medical College, Nagpur. This was followed by residency in internal medicine at the Cleveland Clinic and fellowship in hematology and medical oncology with advanced training in lymphoma at the Mayo Clinic, Rochester. Her areas of expertise are Hodgkin, non-Hodgkin lymphoma, chronic lymphocytic leukemia, bone marrow transplantation, and cellular therapies, including CAR-T. Her clinical research focuses on survivorship, health outcomes, and patient-reported outcomes. She's authored 22 peer-reviewed articles and has been the principal investigator of 3 clinical trials in addition to multiple conference presentations. She will lecture on DLBCL Management in 2023. Thank you, and over to her. Priyanka, you are muted.
Sorry about that. Thank you so much, Dr. Agrawal, for the introduction, for the invitation to present. And it is so wonderful to see so many of my colleagues that I went to school, medical college with here as discussants today. And I grew up hearing Dr. Agrawal speak when he was invited to Nagpur for many seminars. And I used to be the person bringing the flowers to felicitate him. So I think this feels very special to be invited to speak at a webinar organized by him. So again, thank you very much. It's my honor and pleasure to be here today. So I'm going to talk about diffuse large B-cell lymphoma in 2023, and I changed the subject to how I treat because there may be some nuances in management that I do in my practice, which may not be what is universally done for diffuse large B-cell lymphoma. These are my disclosures. And we're going to focus today on the latest developments in aggressive B-cell non-Hodgkin lymphoma in the last 5 years, including diagnostics, classification, treatment in the frontline setting, as well as treatment in the relapse setting. And I can tell you the developments in the last 5 or 6 years have been way more than what we had even in the last 5 or 6 decades with diffuse large B-cell lymphoma management. So this is nothing new to the audience here. We know that diffuse large B-cell lymphoma is the most common type of non-Hodgkin lymphoma. It comprises about 1/3 of all cases of lymphoma that are diagnosed, and this is data from the United States. I show this, which is an outdated 2016 classification, to show that there were more than 10 different types of aggressive B-cell lymphoma that are classified under the WHO classification. And diffuse large B-cell lymphoma, NOS, is the most common, but there are many other subtypes which we will not go into details about, and there isn't a lot of data, and generally they're managed as diffuse large B-cell lymphoma is. There have been updates to the classification of lymphoid neoplasms in the last year with the publication of the International Consensus Classification in Blood, as well as the WHO classification 5th edition that was also updated in the journal Leukemia. And why were these classifications updated is because of better understanding of the classification or the genetic and molecular drivers of diffuse large B-cell lymphoma. And here I show a figure from a review article that was published in the NEJM in 2021, which shows that previously we had learned of the gene expression profiling of diffuse large B-cell lymphoma and classification of it as germinal center B-cell phenotype versus activated B-cell-like phenotype. And based on this classification, there was even the immunohistochemical diagnostic algorithm developed by Hans, which is often used in clinical practice to report the biopsies as germinal center activated B-cell subtype. And this is because the ABC subtype has been shown in studies to have worse outcomes compared to the GCB subtype. And at the same time, the GCB subtype is often molecularly associated with underlying indolent etiologies such as follicular lymphoma and tends to have late relapses. Over the last few years, we've had multiple other molecular subclassifications of diffuse large B-cell lymphoma, like the LymphGen classification, the DLBCL clusters, which were published. And they are not yet available in clinical practice because they involve molecular testing, which is not available in real time at this point. But this figure is to show that there have been many more understandings in terms of the molecular classification that may lead to, in the future, more personalized treatment of diffuse large B-cell lymphoma, depending on the mutations and genetic subtypes that individual's disease may belong to. This is from the ICC update, which shows that over time, our diagnostics have certainly improved, and biopsy collection with immunohistochemistry, which was the basis of diagnosis, is now supplemented in all cases by performance of EBER in situ hybridization, FISH analysis looking for gene rearrangements of MYC, BCL2, and BCL6, as well as B-cell clonality analysis where needed, based on which specific entities such as EBV positive DLBCL, primary mediastinal, primary CNS lymphoma, or high-grade B-cell lymphoma, which used to be called double or triple hit lymphoma, can be identified. The future of clinical practice probably includes circulating tumor cells, cell-free DNA, genomic analysis of targeted NGS panels, using the molecular group classification that I showed you before, and leading to personalized therapy. But we're not there yet. This is to just highlight the reclassification based on the FISH testing that we know for diffuse large B-cell lymphoma, Burkitt lymphoma, and high-grade B-cell lymphoma. The latest WHO classification separates out BCL6 and MYC gene rearranged lymphomas into diffuse large B-cell lymphoma and high-grade B-cell lymphoma, NOS, or not otherwise specified, and only leaves MYC and BCL2 gene rearranged lymphomas in the category of double hit lymphomas. And that's because the outcomes with MYC BCL6 gene rearranged lymphomas seem to be not as bad as those with gene rearrangements in MYC and BCL2 plus BCL6, which would be the triple hit lymphoma. In addition, the WHO latest classification also regroups some of the prior entities, like primary diffuse large B-cell lymphoma of the CNS is now separated out based on whether it is EBV positive or negative. If EBV positive, it is grouped together with immune deficiency dysregulation associated lymphomas. If EBV negative, it is grouped together with diffuse large B-cell lymphoma of organs such as the testes or vitreoretina to come into the category of large B-cell lymphoma of immune privileged sites. In addition, this also separates out MYC with BCL2 gene rearrangements from MYC with BCL6 gene rearrangements, which flow into the category of not otherwise specified lymphoma, diffuse large B-cell or high-grade based on histology. So just to review for the group, aggressive B-cell non-Hodgkin lymphomas are malignancies of the mature B-cell. They can occur de novo versus as a transformation from indolent B-cell lymphomas like CLL, lymphoplasmacytic, follicular, marginal zone, or even nodular lymphocyte predominant Hodgkin lymphoma. The identified and established risk factors for lymphoma occurrence are age, EBV, positivity or viremia, immunodeficiencies, as well as immunosuppression, such as with organ transplant. The clinical presentation is generally acute with rapidly progressive lymphadenopathy. A third of patients present with B symptoms, 60% have advanced stage disease, a third have bone marrow involvement at diagnosis, and 40% have extranodal involvement, most commonly of the GI tract. The diagnosis is established by a biopsy, and excision is a gold standard, but core needle biopsies are often done for inaccessible sites. In addition to immunohistochemistry, flow cytometry, FISH studies, EBER testing is required. Staging is based on PET-CT. We've moved away from doing bone marrow biopsies in lymphoma because PET is very sensitive to detect disease in the bone marrow. However, if the PET scan is negative for bone marrow involvement and you're trying to treat someone as limited stage disease, that may be a situation where a bone marrow biopsy will change management and should be performed. MRI scan of the brain and spine, as well as CSF analysis with flow cytometry of the CSF is important for CNS staging in certain situations, which we will review in the next slide. And then pre-treatment evaluation still includes echocardiogram, looking for immunodeficiencies such as HIV, hepatitis B testing due to risk of reactivation with rituximab treatment, and then remembering fertility preservation if younger patients of childbearing age are in your clinic. Staging does not need to be reviewed here for this group, but I will just show the slide to remind you that staging is based on the Ann Arbor system and is different from other solid malignancies. There are multiple prognostic indexes that have been developed for diffuse large B-cell lymphoma. The oldest and most established one is the International Prognostic Index, which takes into account age greater than 60, performance status, elevated LDH, more than one extranodal site of disease, and Ann Arbor staging 3 or 4. In addition, there was the CNS IPI published in 2016, which included the IPI factors as well as the kidney adrenal involvement, which is used for identifying patients at higher risk of CNS relapse, and those are the patients I would definitely stage the CNS. Moving on to treatment, frontline treatment since the 1970s has been curative intent anthracycline-based chemo, and R-CHOP has been the standard of care for more than 2 decades. I show here 2 figures, the one on the left from the study by Fisher et al. Published in NEJM 1993, where they tried to intensify treatment with additional chemotherapeutic agents compared to CHOP and found no differences, and that's why CHOP remained the standard of care. And then, of course, the practice-changing study in 2002, where rituximab showed a more than 20% improvement in progression-free and overall survival when added to R-CHOP, and this has remained our standard of care for many decades. Multiple unsuccessful attempts over the last many years to improve on R-CHOP, including increasing the number of cycles to 8, increasing frequency to every 2 weeks, increasing doses such as mega CHOP, consolidation with autologous stem cell transplant for all comers after R-CHOP was also an unsuccessful attempt. The anti-CD20 backbone, adding more rituximab doses, changing to obinutuzumab did not work for diffuse large B-cell lymphoma management. Maintenance strategies were attempted and failed, as well as multiple studies of R-CHOP plus X, where X included bortezomib, lenalidomide, ibrutinib, and did not show an improvement overall. However, the intensification of treatment with dose-adjusted EPOCH was thought to be promising, but when compared head-to-head in this study by Bartlett in 2019, published in JCO, showed no improvement in progression-free survival, but showed significantly a higher toxicity with infusional dose-adjusted EPOCH compared to R-CHOP. This was, however, in all comers, and there is probably a role for dose-adjusted EPOCH in some higher grade lymphomas. In the last couple of years, though, we have seen finally a winner in the frontline setting with the addition of polatuzumab vedotin to R-CHOP with the removal of vincristine, and we'll go over this study next. So polatuzumab vedotin is an antibody drug conjugate targeting CD79B. This was initially approved in 2019 for relapsed refractory diffuse large B-cell lymphoma in combination with bendamustine and rituximab. And then we saw the results published from the POLARIX study, which is the multi-center double-blind placebo-controlled phase 3 randomized trial of polatuzumab R-CHP versus R-CHOP. This included 800 and more patients and showed an improvement in progression-free survival of about 6.5 percentage points with no increase in toxicity with the addition of polatuzumab. This is the schema of the study where patients with IPI 2 to 5 were included and randomized 1:1 with Pola R-CHP versus R-CHOP, and progression-free survival was the primary endpoint. And as discussed, there was a significant improvement in progression-free and event-free survival. However, the overall survival data is yet to mature and has not shown a significant difference in overall survival with frontline addition of polatuzumab. So in April 2023, so just this year, we saw this combination approved in the frontline treatment of DLBCL or high-grade B-cell lymphoma with IPI 2 or greater. So just to review some specific scenarios in the frontline treatment, which are often the subject of questions that come up after talks like this. In situations where we have high-grade B-cell lymphoma with MYC and BCL2 gene rearrangements, that is a situation where I would consider infusional dose-adjusted EPOCH or even intensive treatment, such as the modified McGrath regimen shown here. For elderly frail patients, there is data to reduce the doses of R-CHOP, and so R-mini-CHOP is recommended. For patients who have congestive heart failure, substitution of anthracycline with etoposide and gemcitabine also has some phase 2 data to support its use. Concurrent CNS involvement is very challenging to treat, but that is often treated with addition of mid-cycle high-dose methotrexate to R-CHOP, and this is when there's established involvement of the CNS. With patients who have high CNS IPI alone with no involvement of the CNS at diagnosis, data over the last few years actually does not support benefit of CNS prophylaxis with high-dose or intrathecal methotrexate. However, these are retrospective studies, and there may be scenarios you could argue to continue to use prophylaxis methotrexate in the frontline setting. If there's residual uptake on end of treatment PET scan at sites of bulky disease, radiation remains a tool that we use for diffuse large B-cell lymphoma. So post-treatment, when patients have achieved a complete remission, follow-up is usually with labs and visits. Scans are usually not used for surveillance in aggressive lymphomas unless there were some residual findings on the end of treatment PET that need to be followed up. And we generally do not use maintenance for any aggressive B-cell non-Hodgkin lymphoma because our hope is we have cured them in our first attempt. To summarize frontline treatment of diffuse large B-cell lymphoma, I have this algorithm here. We did not talk about limited stage disease in detail, but for stage 1 and 2 diffuse large B-cell lymphoma, treatment choice really depends on whether there are any IPI risk factors, whether they have bulky disease, and you may consider abbreviated 4 cycles of R-CHOP based on the recently published FLIER study, or a combined modality treatment where you use R-CHOP 3 to 6 cycles with or without radiation. Moving on to relapse refractory aggressive non-Hodgkin lymphoma or diffuse large B-cell lymphoma, there is incidence of primary refractory disease that does not respond or inadequately responds to frontline treatment of about 10%. And relapse disease does occur even after initial complete response in about a third of patients. Majority of these relapses occur in the first 2 years after treatment completion, and I will show some data that supports why early relapse within a year after initial treatment completion should be treated similar to refractory disease. So we know that at relapse of diffuse large B-cell lymphoma, chemotherapy alone is not curative, and this was based on the PARMA study published many years ago, which looked at just conventional chemotherapy at relapse versus the addition of autologous stem cell transplant, showing a survival benefit with about 50% cure rate with autologous stem cell transplant added to second-line chemotherapy. This is data from the CORAL study to emphasize that in patients who have an early relapse, which is the graph here on the left, versus patients who have a late relapse, especially in the rituximab era, which is the yellow line on the graph here, early relapse within 12 months has significantly worse prognosis with a progression-free survival median of only 6 months compared to if they have late relapses. And that's why our approach to treatment really differs depending on the timing of relapse. So important factors when someone presents with relapsed DLBCL is their fitness for intensive chemotherapy or intensive treatments and the timing of the relapse. How is fitness determined? We know that age itself is not a defining factor, and I think this concept is even more fluid in the era of CAR T, whereas with transplant, we used to sometimes have a hard cap of no transplants above age 75 due to the risk of complications. For CAR T, I think we don't really have an age limit. We take into account medical history, comorbidities, and definitely performance status and level of functioning in day-to-day activities. If a patient is considered fit, then the treatment is with curative intent, and then we take into account the timing of relapse. If more than 12 months, then CAR T versus autologous stem cell transplant is decided based on chemosensitivity, versus if the relapse has occurred early or the patient has primary refractory disease, then CAR T is now approved in the second-line treatment of diffuse large B-cell lymphoma just in the last year. So let's talk about the late relapses first. This is the algorithm we follow. We treat patients with second-line or salvage chemotherapy for 2 to 3 cycles. What treatment you choose, really, there hasn't been any head-to-head trial to say one is better than the other. At our center, we prefer gemcitabine-based regimens like R-GEMOX or R-GDP, given that they're more outpatient-based versus R-ICE, which is inpatient-based. After the 2 to 3 cycles, a PET scan is performed, and based on response, if there is chemosensitive disease, patients are taken to high-dose chemotherapy with autologous stem cell rescue. However, if patients have a PET scan with only partial response or no response or progression or refractory disease, then CD19-directed CAR T cells are used, and we have 3 agents approved in this setting. What is CAR T? Just to review briefly for those who may not be familiar, it is an immunotherapy using the patient's own T lymphocytes. These cells are engineered to express the chimeric antigen receptor that directs them to a particular target, which is CD19 in lymphoma. It involves the process of leukapheresis, manufacturing in a lab facility using a viral vector to induce this CAR receptor in the T cells, after which they're harvested and sent back. And it takes about 3 to 4 weeks for the manufacturing process to occur for the commercial products that we have available today. There are unique toxicities to CAR T, like cytokine release syndrome, immune effector-associated neurotoxicity syndrome, in addition to infusion reactions, infection risk, cytopenias, and hypogammaglobulinemia. There are many things that we probably don't understand about the long-term effects of CAR T at this moment because our experience with it is limited. The CD19 targeted CAR T products that are approved in the third-line setting are shown here with regards to their structure. There are some minor differences, like the co-stimulatory domain in axi-cell is CD28 versus 41BB in tisacel and lysocell, and we have seen more neurotoxicity, which is thought to be because of the different co-stimulatory domain with axi-cell. In addition, the structure of the CAR T cell can be different based on the product that we are using. This table here just summarizes the data from the pivotal trials, which was ZUMA-1 for axi-cell, Juliet for tisacel, and Transcend for lysocell, which shows overall similar response rates and similar progression-free survivals in the 40 to 60% range. The response rate in terms of complete response is in the 40 to 50% range, which is pretty remarkable for patients enrolled on these studies who were heavily pretreated. I already pointed out differences in terms of toxicity with higher cytokine release syndrome and neurotoxicity with the axi-cell product, and significantly lower with the lysocell product that is our preferred product at this time. And why are we excited about CAR T? Because more than 40 to 50% of patients with refractory or relapsed diffuse large B-cell lymphoma may still be cured with CAR T. And these are graphs where you can clearly see a plateau after long-term 5-year follow-up with the pivotal axi-cell study that was done in the third-line setting. For patients who have early relapse within 12 months or have primary refractory diffuse large B-cell lymphoma, we will go over the data for CAR T, and we have 2 products that are approved in the second-line setting, which is axi-cell and lysocell, both approved within the last year. The third product, tisacel, was not approved because the second-line study was not positive, and there were lots of discussions which we can go over in terms of why we think that study was unsuccessful in showing the benefit of tisacel in the second line. To summarize again, axi-cell versus standard of care, including autologous stem cell transplant in the second-line setting, was tested in the ZUMA-7 study, which was an international phase 3 randomized trial, including more than 350 patients, and has about 47 months of follow-up in the latest update that was published or presented. The overall response rate with axi-cell was 83% versus 50% with standard of care, with 65% complete response rates. And the latest update showed that axi-cell improved not just progression-free survival, but also overall survival when used earlier in the second-line setting compared to standard of care. And so based on the overall survival benefit, we've definitely adopted second-line CAR T-cell therapy for these high-risk early relapsing or primary refractory patients. The lysocell study was similarly designed, comparing to standard of care, including autologous stem cell transplant in the second-line setting. This was called Transform. And this has a shorter follow-up and did not yet show an overall survival benefit, but definitely has a significant event-free survival benefit when used earlier in the second-line setting compared to standard of care approach. There is data for using lysocell in the second-line setting for patients who would traditionally be considered ineligible for autologous stem cell transplant, and this was a phase 2 pilot study where the median age of enrollment was 74 years, and majority of patients had primary refractory or early relapse of their disease. Overall response rate was great at 80%, with complete response rates about 54%, and this study proves that lysocell can be safely administered to elderly patients, and there were no excessive toxicities seen even with the higher age group. So the algorithm for management of first relapse of DLBCL has definitely been updated very recently, where the timing of relapse matters. And if the patient has early relapse and is a candidate for intensive treatment, CAR T-cell therapy should certainly be used. If late relapses occur, then we use a standard salvage, and based on response, move on to CAR T or autologous stem cell transplantation. And hopefully patients who achieve CR maintain their CR and can be observed. If patients do have a second or later relapse, then we'll talk about the additional agents that are available. So what about the patients who relapse after intensive treatment or are considered unfit for intensive therapy? Then our approach is really palliative intent with the goal of disease control and symptoms while maintaining quality of life. And we have many treatment options that, if used in sequence, we're probably talking about giving them many months or few years of disease control with sequential use of these many agents. Previously, the choice of therapy, and even now, is based on prior treatment history, toxicity profile, as well as the logistics of administration. Traditionally, we use lower intensity chemotherapy or radiation alone, but since 2019, we've had 6 products or drugs that have been approved, including bispecifics just now earlier this year. So going over these one by one really quickly, polatuzumab vedotin, we already covered in the frontline setting, is an MMAE microtubule inhibitor conjugated to a CD79B monoclonal antibody. And this was initially approved in the relapse refractory setting in 2019 based on this study, which compared Pola-BR versus BR. This was a phase 2 study, but randomized patients who had received at least one prior line of therapy to polatuzumab in combination with bendamustine rituximab versus standard doses of bendamustine and rituximab for 6 21-day cycles. The primary endpoint was CR rate. But we also saw that there was an improvement in overall survival on the updated analysis with the addition of polatuzumab to bendamustine rituximab. There is the significant toxicity of peripheral neuropathy with polatuzumab, and I will point out that in terms of CR rate, about 50% of patients did achieve a CR. The benefits of this regimen are the fact that it is time limited for 6 cycles, and we often reach for polatuzumab as a bridging agent when patients are waiting their CAR T manufacturing, but have to use caution with bendamustine due to its lymphodepleting effect. Moving on to tafasitamab lenalidomide. Now, tafasitamab is a monoclonal antibody directed to CD19, which is given in combination with lenalidomide, which is an immunomodulatory agent. And this has also been studied and approved for patients who are not candidates for intensive therapy in the second-line setting. This was based on the L-MIND study, which was, again, a phase 2 study enrolling patients with at least one prior line of treatment. Lenalidomide is administered for 3 out of 4 weeks in each cycle at the dose of 25 milligrams per day. The tafasitamab treatment schedule is fairly intensive with weekly infusions initially for the first 3 cycles, after which it is an every 2-week infusion. So it does require a lot of visits for the patient in order to get the adequate doses. And then management of toxicities with lenalidomide is often the limiting factor. However, again, response rates overall were in the 60% range with 40% CRs. And as you can see in the figures here, patients who achieved CR, shown in the orange, definitely had longer duration of responses and progression-free survival compared to patients who did not achieve a response. The notable toxicities are related to the lenalidomide, with neutropenia, thrombocytopenia definitely being significant and difficult to manage sometimes. The other agent which was approved and directed towards CD19 was called loncastuximab tesirine. This is an antibody drug conjugate, so similar to polatuzumab, but completely different target, CD19, as well as a different payload, tesirine, which is cytotoxin causing interstrand DNA crosslinks. This agent was studied in a phase 2 study as well, and was given as an every 3-week infusion. So the schedule is different from the other agents that we just reviewed. These were heavily pretreated patients, and we saw overall response rates of close to 50% with about 24% CRs. Again, important to note that the median duration of response was 10.3 months in anybody who responded, and patients who achieved a CR definitely had longer progression-free survival compared to those who did not. The main toxicity related to loncastuximab, which needs to be kept in mind, which is different from other agents that we use, is this risk of edema and effusions. And so someone who already is struggling with those symptoms should not be treated with loncastuximab. The question then comes up, we have so many CD19 targeted therapies at this point with loncastuximab, tafasitamab, lenalidomide, and of course CAR-T. Is there data to sequence it? And even though the data is not robust, there are smaller studies that I show here where CD19 expression after loncastuximab tesirine doesn't seem to be affected, as well as the response to CAR-T is not affected if loncastuximab is used prior to CAR-T. So preliminary studies do suggest that sequencing of CD19 targeted agents do not preclude later use of CAR T-cell therapy. Selinexor is another agent that has received FDA approval for use in diffuse large B-cell lymphoma that is relapsed refractory after 3 lines of therapy. The advantage is it's an orally available agent, has a different mechanism of action by selectively inhibiting nuclear export, but the outcomes are much less significant or impressive compared to the other agents, with overall response rate of 30% with 12% CRs. However, again, if patients achieve a CR, the duration of response was close to 2 years. It is limited in terms of its administration due to its toxicity, with cachexia, fatigue, nausea, and low blood counts being significantly difficult to manage. So it is not an agent we reach out to, especially given all the options we have available for our patients. The next exciting development since CAR-T has been the development of bispecific T-cell engagers, and these are bispecific antibodies, which you can see here in the figure, have one arm that goes to CD20, which is present on the lymphoma cell, and the other arm reaches out to CD3 on the T cell, leading to T cell recruitment, activation, and cytotoxicity. And this figure here on the right shows the multiple bispecific agents that have been studied and are being looked at in lymphoma. And mosunetuzumab is one that has been approved for follicular lymphoma, and the 2 agents, glofitamab and epcoritamab, which we will review in more detail, have been approved for diffuse large B-cell lymphoma just in the last few months. The other agents here are early in development and have shown promising data and may be approved in the coming months to years. These agents are different in terms of their structure. They are indifferent in terms of their response rates with regards to indolent versus aggressive, which are shown in the blue and green graphs here on the top. And then the CRS rate, which is the cytokine release syndrome rates, are also different depending on the agent and the setting in which they have been studied. So talking about the approved agents, which is epcoritamab, this is a subcutaneously administered CD3, CD20 bispecific antibody, and it induces T cell activation by binding to CD3 on T cells, CD20 on malignant cells, resulting in an immunologic synapse and apoptosis of the B cells. It binds to a distinct epitope that's different from what rituximab would bind to on CD20, and so it retains activity even in the presence of or in patients who are refractory to other anti-CD20 agents. And this was the EPCOR NHL-1 study, which was a phase 1, phase 2 study. Initial dose escalation established the 48 milligram dose as the recommended phase 2 dose. And this included some heavily pretreated patients with a median of 3 prior lines of therapy, but up to 11 prior lines of therapy. Included patients who had received prior CAR-T, 39%, including 75% who had progression of disease within 6 months of prior CAR-T. The follow-up is short, only 10.7 months, and the reasons for discontinuation of treatment in a majority of patients was progressive disease on this study. But what it showed was response rates of 63% with close to 40% CRs. And again, the graph here on the left shows patients who achieve a complete remission definitely can have a long duration of response and a long progression-free survival. The post-CAR-T and primary refractory subgroups also had CR rates in the 30% range, which is very encouraging with the bispecific agents. In terms of toxicities, because these are T-cell engagers, they do cause cytokine release syndrome, and they have to be managed at a center that can manage the cytokine release syndrome. They're administered as a step-up dose, where we can see the priming dose with cycle 1, day 1 is a minuscule 0.16 milligram dose, cycle 1, day 8, 0.8 milligram dose, and the first full dose is only reached on cycle 1, day 15. And a mandatory hospitalization is required by the FDA to monitor for cytokine release syndrome, which can occur in up to 50% of cases, majority of which have been grade 1 or 2 on this study, but real-world data remains to be looked at. The CRS does require treatment with steroids as well as sometimes with tocilizumab in about 15% of cases. And there have been cases of neurotoxicity in about 6%, majority a grade 1 to 2, but there was a fatality in the setting of neurotoxicity on this study. And so we need to be cautious when starting to administer these agents. Glofitamab was the second bispecific antibody that received FDA approval for diffuse large B-cell lymphoma just this year. And this is different from epcoritamab in the sense that it has a different configuration. It has a 2:1 ratio of targeting CD20 to CD3. So it double binds to CD20 and so is thought to have superior potency based on preclinical studies, but also has increased toxicity that requires pre-dosing with obinutuzumab. It is given IV. It is different from epcoritamab in the sense that it is a time-limited treatment given over just 12 cycles. And this was the phase 2 trial that was recently published. The administration involves obinutuzumab on day 1, followed by step-up dosing of glofitamab on day 8 and day 15, with the first full dose administered on cycle 2, day 1. However, with glofitamab compared to epcoritamab, and I think this is the next slide. Oops, sorry. I think we'll go over it. In terms of the toxicity is highest with the day 8 dose. So the timing of hospitalization is different based on which bispecific agent you are using for your patient. This study also included heavily pretreated patients with 60% more than 3 prior lines of treatment. 30% of patients had received prior CAR-T, and majority of them had primary refractory disease in 90% of cases. This was the follow-up after 12 months, which showed an overall response rate that was in the range of 50%, with 40% of patients achieving a complete response. And again, looking at the subgroups that were post-CAR-T or had primary refractory disease, the response rate was still close to 35%. The median duration of response in all patients was about 63% at 12 months, and patients who achieve a CR obviously did better with this agent as well. This was what I was talking about in terms of the toxicity. You can see the CRS occurs earlier with glofitamab, and that's why the pre-dosing with obinutuzumab is recommended to clear any circulating B cells, which could make the CRS rate higher. There were fewer rates of grade 3 and grade 4 toxicity, CRS seen, and again, required corticosteroids, tocilizumab. ICANS or neurotoxicity was seen in about 7.8% of cases. So this is just a summary of these two agents, the main differences being route of administration, subcutaneous, given continuously versus fixed duration IV. In terms of response rates and toxicity, they look very similar except for differences in the timing of toxicity. Other palliative treatments sometimes still need to be used, like lower intensity or single agent chemo, radiation for symptom control, and then, of course, steroids, which can palliate a lot of lymphoma-related symptoms. This is data from the SEER showing lymphoma patients living longer, but only up to 2017. And with these new barrage of agents that we had in the last few years, hopefully the data that is updated from SEER will look even better. So to summarize, we have a new classification, improved diagnostics for DLBCL in the last many years. We have frontline approval of POLA-R-CHP in addition to R-CHOP. We treat patients differently based on whether they have early relapse or primary refractory disease, where we reach for CAR-T sooner as our standard of care. But for late relapses, we still give them salvage and autologous stem cell transplant if they have chemosensitive disease. For second-line transplant ineligible patients, we now have many options, including liso-cel, which is probably the safer of the CAR-T options. And then in the third-line setting, we have so many agents that we don't really know what the ideal sequencing strategy is at this time. We have 2 approved bispecifics, which look very promising and maybe things that can be taken to places where CAR-T access is very limited. And then hopefully the future will show us novel agents incorporation into earlier lines of therapy like we've seen with polatuzumab. And with that, I will end my talk and take any questions.
Thank you, Dr. Priyanka. That was wonderful. A comprehensive review of everything that has happened in the last 5 years. You reviewed it so beautifully. We'll wait for the raise hand signs. Meanwhile, may I ask you some questions?
Absolutely.
So, regarding the use of POLA in the first line, no overall survival, your comments?
Yeah, so we always have to wait for overall survival data, right? So the study doesn't have adequate follow-up yet. We know that relapses occur early, but now we are also salvaging patients with CAR T-cell therapy, which is also curative intent. And so we may or may not see a difference in overall survival. I think as the data matures, it'll be helpful to see how many patients needed second-line treatment, how many patients actually relapsed. And so I don't think it has been adopted universally for all patients. I tend to use it for patients who have a very high IPI, where I'm worried that they're not going to be candidates for autologous transplant or CAR-T in the second line setting. Then I want to, give them the best shot of cure with frontline treatment. And so those are specific scenarios where I'm maybe picking and choosing patients to treat with POLA-R-CHP at this time versus using R-CHOP since we have it available. But I don't think that with just a progression-free survival benefit of 6%, it is something that we can say every patient with diffuse large B-cell lymphoma should get, because R-CHOP is definitely an excellent treatment.
Any comments between the ABC and GCB subtype for the use of POLA?
Yeah, so there is a subgroup analysis from the POLARIX study, as well as a recent publication that looked at multiple studies with polatuzumab and the differences between responses in ABC and GCB subtype. And certainly it looks like it may be more beneficial for patients in the ABC subtype. But as I also showed, there's complexity to our to the understanding of the subclassification of DLBCL, and maybe in the coming years with the molecular classification coming into practice, we'll understand more who within GCB could also benefit from POLA. So yes, I do think about POLA for ABC subtype, but there may be more to learn, and I wouldn't necessarily again say that everybody with ABC subtype should receive polatuzumab frontline.
And when you are using POLA with BR for the relapsed patients, and if the patient is a candidate for CAR-T, then you are dropping bendamustine, or you wait after bendamustine for a long time?
Yeah, so I think when we use polatuzumab for patients who are CAR-T eligible, it depends on when we're using it. So if we are like trying to wait for a CAR-T manufacturing slot and we haven't yet leukapheresed the patient and collected their T cells for manufacturing, then we certainly want to avoid bendamustine. And in that setting, I use polarituximab. I don't think it is a very effective agent, but it is enough to control the disease and time to get to the leukapheresis. Once the leukapheresis is done and you've collected the T cells, I think there's no downside to giving bendamustine. And so if I'm using it as a bridge, I often use Pola-BR with the caveat that when we add bendamustine, the cytopenias are more prolonged, and so it might delay the time to CAR T. So it just depends on where in the CAR T process you're trying to use Pola is how you decide whether you add bendamustine or not.
Thank you. Soumya, your question.
Yeah, thank you. It's nice presentation, Dr. Priyanka. Fantastic, lucid presentation. Actually, I have one basic question. What is the role of interim PET, though we're not regularly doing for DLBCL? But in your clinical practice, can you just elaborate whether you are using for, especially in few patients with high-grade patients, the role of interim PET? It is my first question. And my second question, yeah, okay.
Let's have the answer, yeah.
Yeah, thank you.
Yeah, so that's an excellent question. And I think the data for interim PET for diffuse large B-cell lymphoma is definitely not as clear-cut as it is in Hodgkin lymphoma, where we have PET-adapted strategies. The place where we would definitely use a PET scan is for early-stage patients where you're looking to abbreviate therapy. There is evidence, or the strategies can be PET-adapted by doing a PET after 3 cycles of R-CHOP and then deciding whether you eliminate radiation altogether or intend to do a full 6 cycles, depending on the degree of response. So for early stage patients, I definitely PET them after 3 cycles to determine the duration of therapy. For patients who have advanced stage disease, I think it, like you said, I do use interim PETs, and I use them in patients where I'm worried. So if they have high risk disease, they have disease that is not easily palpable, mostly internal disease, which I can't visualize, and I want to make sure they aren't in that small proportion of primary refractory cases, then in that situation, I use that interim PET. As long as I'm seeing a response, I don't change my treatment strategy, but there are times where the primary refractory patients are already progressing despite getting R-CHOP or clinically feeling better, but their scans look worse. And so those are situations where I may use an interim PET scan, but not universal for all patients.
Yeah, thank you. My second question is that in the L-MIND trial, you have mentioned for the tafasitamab with, I think, lenalidomide is. So any data if you can use tafasitamab with the other agents, because sometimes actually one of my patients is intolerant to lenalidomide. So can we use some other drugs with tafasitamab? Any data for that?
So not that I'm aware of at the moment. I think tafasitamab is being studied in combination with lenalidomide, like even in the frontline study that they have designed right now, it is TAFA R squared CHOP. So they have included lenalidomide as activity of single agent. Tafasitamab doesn't seem to be very impressive. And so they require the combination with len. I have not come across any data with other agents. But if your patient is intolerant of lenalidomide, maybe you want to choose something other than tafasitamab-len combination.
Thank you, Dr. Priyanka. Thank you all. It is a Durga Puja time from West Bengal, Kolkata. Yeah. So wish you a happy Durga Puja to all of you.
Thank you,
To
sir.
you as well. Thank you.
And Nishant, your question.
Hello, that was a wonderful presentation, Dr. Priyanka. My question is about double hit lymphomas. So the POLARIX study did show, I think, a good response in double hit lymphomas. So what is your current line of management, whether it is dose-adjusted EPOCH or whether it is Pola CHP?
Yeah, so I think patients who can tolerate Polar CHP versus dose-adjusted EPOCH are inherently different. So I think for double hit lymphomas, which is MYC and BCL2 gene rearranged, I don't think I would intensify necessarily for just BCL6 rearranged. I do consider escalating treatment to dose-adjusted EPOCH if I think they will be able to tolerate it. And now with Pola chip available and including patients with high-grade B-cell lymphoma, I think if the patient is unable to tolerate dose-adjusted EPOCH, instead of going to R-CHOP, I'll probably use Pola R-CHIP in those situations. So yeah, great question.
Okay, one more question, sir. Ma'am, this is about CNS prophylaxis. So in this current scenario, do you use CNS prophylaxis in any subset of patients like testicular lymphoma, breast lymphomas, paraspinal masses?
I do. And yes, for those exact very subsets, because I think the multicenter retrospective studies didn't have really big numbers of testicular or breast lymphoma. They did look at epidural and didn't see any significant difference, but you obviously worry with the known higher CNS relapse in these situations, given the proximity. So depending on how the patient is tolerating it. But I think the major takeaway from the studies that were published is that your CNS prophylaxis should not compromise your systemic treatment. So trying to do high-dose methotrexate and causing a delay in their R-CHOP or pola-R-CHP is probably not recommended. But if your patient is sailing through methotrexate and you want to add a prophylaxis which doesn't delay their systemic treatment, I don't think you'll be, wrong in doing that.
And what about double hit and high grade lymphomas?
Yeah, there
They still
I
need?
certainly do, because the risk of relapse is higher. And if you're using EPOC, intrathecal is already built into the protocol. So that's what I use. I don't add high-dose methotrexate to it. But I will also say that I don't feel strongly for doing CNS prophylaxis. If my patient has major toxicity from intrathecal or high-dose methotrexate, then I avoid it, because I worry that you're going to only compromise their functional status. And then if they need to go to CAR-T or have a relapse in the CNS, then we know we have better tools than methotrexate to treat them at relapse. So I think I use it in certain situations, but I don't push for it if the patient is not tolerating it.
And when you use it, whether it should be mid-cycle or you can use it at the end of completing the cycles?
It depends on, again, how your patient tolerates it. I think giving it at the end of your 6 cycles of treatment, once they've achieved systemic remission, is also okay. I generally don't give it with the first 3 cycles. If I'm going to add it, I add it with cycle 4, 5, and 6 of R-CHOP, so that I know I've given good systemic controlling treatment before I attempt to do CNS prophylaxis. So yeah.
Thank you so much, ma'am. Thank you so much.
Thank you, Nishad. Amit?
Yeah, thanks for that wonderful talk. Regarding this chemo-refractory DLBCL, in our Indian setting, many of the patients cannot afford for CAR T-cell therapy and novel agent therapy. So what is your take on these 2 therapies? For one is the SMART trial, which was published, that is ACAL plus LEN plus rituximab. And another one is the role of PD-1 blockers in DLBCL. Your take on that. Can we go for this patient's PD-1 blockers and go for ACAL, LEN or ibrutinib or acalabrutinib plus LEN plus rituximab?
Yeah, so I think to your first point, it really depends on the subtype. So if you have a patient with ABC subtype, they have shown better responses in the frontline studies that included ibrutinib, lenalidomide, and even in the relapse setting, there's definitely phase 2 data for using these targeted agents in the ABC subtype. For the GCB subtype, I'm not so convinced that using a targeted or targeted inhibitor is going to be the right approach. Although tafasitamab lenalidomide probably works as well in GCB. So I would decide that based on the molecular subtype, but you're not wrong when you don't have access to CAR-T or these newer agents to use what you have available. However, with regards to checkpoint inhibitors, I think there's been a lot of negative studies published in diffuse large B-cell lymphoma. So I do not recommend using checkpoint inhibition in diffuse large B-cell lymphoma. There are some ongoing, early phase studies looking at checkpoints with the addition of, multiple checkpoint inhibitors, combinations, trying to see if there may be mechanisms by which diffuse large B-cell lymphoma can respond to this strategy, but so far it's not been very successful. So I'm not sure that I would recommend checkpoint inhibitor, except primary mediastinal B-cell lymphoma. If you have a case, then that is more likely to respond. Histiocyte-rich B-cell lymphoma, more likely to respond. So those are cases where you may consider checkpoint use, but in standard NOS DLBCL, I wouldn't recommend it.
Thank you.
Thank you, Amit. Vishudip?
Good evening, sir. Excellent talk, ma'am. There's one doubt, like if the patient presenting with HLH, like pancytopenia and marrow shows involvement with lymphoma, and flow is suggestive of B-cell lymphoma in between Like you cannot differentiate between Burkitt's and DLBL. So if we send CMYC and it comes positive, it can come positive in both double expressor, double hit as well as Burkitt's. So do you have any pointers like how do you go about it, differentiating between two? Mostly the therapy may not change if we treat aggressively both the lymphomas, but is there any pointer which can help us decide to go in which way?
Yeah, this is always a discussion with our hematopathologists, and it's hard. So I think what's important is the morphology. Burkitt has a very distinct morphology, and I rely on my hematopathologist to tell me whether they're more concerned about Burkitt's based on morphology. Second, for Burkitt lymphoma, you will see c-MYC rearrangement or close to 100%. So, 90 to 100% range. They will have a high proliferative index, which can also occur. But I don't believe that you see both MYC and BCL2 gene rearrangements in Burkitt, which is seen in double hit lymphoma. But it's hard to distinguish. And in this situation that you describe, where the patient's presenting with HLH, has bone marrow involvement, like you said, the treatment would probably not change. And so even though semantics, it matters what you call it, it doesn't necessarily matter how you treat it. You are going to try to treat it with curative intent. Hopefully you will try to incorporate etoposide in its management. So whether you choose dose adjusted, EPOC would probably be the right one because it has etoposide in it and would work for both Burkitt as well as high-grade B-cell lymphoma. So no, that is often a dilemma that we face as well.
Thanks.
Thank you. A couple of questions from the audience. Apart from bendamustine, is there any other chemotherapy drug that should be avoided when you're collecting T cells for CAR-T?
That's a good question. I think bendamustine is the main one. It does basically, you want to make sure that your patient has recovered counts from any of their prior treatments. So if you gave them a cisplatin-based or gemcitabine-based second-line treatment, you want to make sure they have an adequate lymphocyte count. I believe the requirement is to have at least 300 on the differential for the lymphocyte count so that you collect an adequate number. But bendamustine is definitely one. Basically, you don't want to use anything lymphodepleting. And so steroids is obviously also another one. You don't want the patient to have been treated with high-dose steroids prior to collection to make sure you have healthy T cells when you collect them. But yeah, besides bendamustine, steroids, you want to make sure you have a washout from all the other agents and good count recovery.
Thank you. Another question they have is, are there any new treatments for primary CNS lymphomas?
I wish. So I think no, methotrexate high dose is still our backbone. There's definitely more and more data for using BTK inhibitors for treatment of CNS lymphoma, but we generally reach for them in the relapse setting. We still use traditional cytarabine, etoposide, thiotepa-based regimens for these patients. There is some evolving data or ongoing studies looking at immunotherapy. And I will say that CAR T cells do penetrate into the CNS, and we definitely have used CAR T cells in secondary CNS lymphomas. It's not approved for primary CNS lymphomas, but study is ongoing, and it does look like it's promising in terms of at least the CAR T cells penetrating into the CNS and giving us some response. Whether that'll be sustained responses or not, time will tell, but very challenging to manage.
Thank you. Other question is, DLBCL diagnosed during second trimester of pregnancy?
Yeah, excellent question. And I don't think I've thought about this for a while. So I always have to reach to our pharmacist and review the literature on what crosses the placenta versus not. So off the top of my head, I don't know what to tell you. I think second trimester, you can treat the patient safely. Depends also on the symptom burden and the stage of the disease. If you can delay till the baby can be delivered before starting treatment. But yeah, it really depends on the individual circumstances and how important or precious the pregnancy is, and how severe the symptoms from the lymphoma are. I've actually seen more primary mediastinal B-cell lymphoma in pregnancy than diffuse large B-cell lymphoma, and have been able to wait if the patient is not symptomatic to treat them after delivery.
Thank you, Priyanka. That was the last question from the audience. So thank you. Have a wonderful day ahead, and thanks for sparing your time and educating this part of the world. It was a tremendous lecture and very interactive question and answer session. Thanks to our discussants also, and thanks to our sponsors also. Thank you. Bye-bye.
Thank you, everyone, so much. Take care.